So AI in healthcare, right? It's a
Yeah.
huge topic. We've all heard the promises, seen the potential, but what about the reality?
Yeah, I mean, it's been, what, over a decade since IBM Watson won on Jeopardy? That was a big deal.
Huge. Everyone was talking about it.
And it really seemed like healthcare, with all its data and complexity, would be the perfect place for AI to shine.
Right, exactly. And one of the earliest, most ambitious attempts was IBM Watson for oncology.
Absolutely. A really fascinating case study, and we've got some great sources that dive deep into what happened, what they were trying to do, what worked, what didn't.
So that's our mission today, to really understand this journey, because it definitely wasn't a straight line to success.
Not at all. You know, it started with this partnership back in 2012 between IBM and Memorial Sloan Kettering Cancer Center, MSKCC.
MSKCC, one of the top cancer centers in the world.
Exactly. And the goals were really ambitious. They wanted to create this system, Watson for Oncology, that could help doctors analyze mountains of medical information, research papers, guidelines, patient data, and then suggest personalized treatment plans, make decisions faster, bridge knowledge gaps, and ultimately improve outcomes for patients.
Yeah, and become a leader in this whole field of healthcare AI.
Right. The idea was that Watson could sift through all this data and offer evidence-based treatment options tailored to each individual.
So how did they go about building it?
Well, the initial development focused on training Watson using MSKCC's clinical guidelines, their research, all their expertise.
Okay, so kind of like feeding it the best practices from one of the leading institutions.
Exactly. But even early on, they ran into challenges.
Like what?
Well, you know, medical language is very nuanced. It's not always straightforward.
It's its own world.
Right. And getting the AI to understand those subtleties, to interpret it correctly, proved to be tricky.
Makes sense.
The first application they tried was for lung cancer treatment at MSKCC, and that was in 2013.
Okay, so pretty early on.
Yeah. And then in 2014, they did some pilot testing, and already limitations were starting to show up. The recommendations Watson was making weren't always practical in a real-world clinical setting.
So it was working in theory, but not necessarily translating to the actual practice of treating patients.
Exactly. But despite those early hiccups, they went ahead with a big launch in 2015.
Yeah, I remember that. There's a lot of buzz around it, a lot of marketing.
Absolutely. And they started getting adoption in different countries: Thailand, India, South Korea.
Wow, so it was spreading globally pretty quickly.
Yeah, they partnered with Manipal hospitals in India to provide online expertise. They were working with doctors in Germany. Even the U.S. Veterans Affairs got involved, and some healthcare imaging providers, too.
So it seemed like it was gaining traction, proving its worth.
On the surface, yes, but behind the scenes, things were starting to change.
Wow.
Yeah, by 2016, there was growing skepticism from oncologists, from the doctors who were actually using it.
Really? So what were they saying?
Well, they felt the recommendations were too simplistic, too generic, and they were also concerned about bias.
Bias. How so?
Because Watson was initially trained mainly on MSKCC's data, their guidelines, it tended to reflect their approach, which might not be the best fit for every patient, every hospital, every healthcare system.
Yeah, that makes sense.
Right. And these concerns were amplified in 2017 when some critical media reports came out.
Oh, yeah, I remember reading about those. They were pretty damning.
Right. They questioned the validity of some of the advice Watson was giving, suggesting that it was sometimes based on hypothetical data.
Not even real patient cases.
Yeah, and there were even reports of unsafe and incorrect recommendations.
Wow, that's serious. And then came the MD Anderson situation.
Right, in 2018, that was a major setback. They had invested a substantial amount of money into this partnership, but it was ultimately terminated.
Because it wasn't working.
The results were underwhelming, to say the least. There's a quote from a doctor involved in the project that really sums it up. Something like, "We had a lot of difficulty getting the data in a way that was usable, and the system was struggling with the complexities."
So not enough data, and the data they had wasn't being processed effectively.
Exactly. And reportedly, other hospitals that had adopted Watson for Oncology also canceled their contracts around this time, citing high costs and lack of performance.
Ouch. That must have been a big blow for IBM.
Definitely. And looking at the bigger picture, it seems like this was the beginning of the end for Watson for Oncology. By 2019, IBM was restructuring its entire Watson Health division.
Right. And then in 2022, they sold off most of the Watson Health assets for $1 billion.
Yeah, a fraction of the $4 billion they had invested.
So a significant financial loss. And what happened to Watson for Oncology specifically?
Well, the assets were rebranded as Merative, and reports indicate that Watson for Oncology was quietly discontinued in 2023.
So the journey that began with so much promise ultimately came to an end.
It's a cautionary tale, really.
But before we get into the lessons learned, I want to understand how this whole thing worked. How did Watson actually learn to do what it was supposed to do?
Right. So it all started with data. They fed Watson massive amounts of information, MSKCC's guidelines, medical literature, hundreds of journals, textbooks, millions of pages of text, and then patient case histories, electronic health records, family history, prior visits, test results, everything they could get their hands on.
Wow, so it was like cramming for a medical exam, but on a superhuman scale.
Exactly. And they were dealing with both structured data, like lab results, which are easy for computers to understand, and unstructured data, like doctor's notes, which are much harder to process.
Right, because human language is messy and ambiguous.
Exactly. So they use something called natural language processing, or NLP, to help Watson make sense of all that unstructured text. NLP is basically teaching computers to understand human language, the nuances, the context, the meaning behind the words.
So it's like giving the computer a crash course in medical jargon and how doctors actually communicate.
Yeah, precisely. And the amount of data involved was mind-boggling. They even analyzed the molecular and genomic data from tumors to try suggest targeted therapies.
So they were really trying to cover all the bases.
And they weren't just throwing data at Watson and hoping for the best. The role of human experts, the oncologists at MSKCC, was crucial throughout the entire development process.
Okay, so it wasn't just a bunch of tech guys in a room trying to build a medical AI.
No, not at all. The doctors guided the development, defined how the data should be used, what questions Watson should be able to answer. They even uploaded question-answer pairs themselves to train Watson.
So they were actively shaping how the AI learned and what it was learning.
Exactly. And they would then score Watson's recommendations, assess how good they were, provide feedback to the engineers.
So there was a constant back and forth between the tech and the medical expertise.
Yeah, a true collaboration. But even with all that effort, there were some fundamental issues that ultimately led to Watson for Oncology's discontinuation.
So beyond the MD Anderson situation, what were the main reasons it didn't work out?
Well, a lot of it comes back to those early concerns, the simplistic recommendations, the bias towards MSKCC's approach. It just wasn't adaptable enough to different clinical settings, different patient populations, different healthcare systems.
And we saw examples of this in India, China, even South Korea, where their insurance system wasn't really compatible with Watson's suggestions.
Right. And then there were those reports of inappropriate or even unsafe recommendations, which obviously raised serious safety concerns.
Yeah, and the fact that it was difficult to integrate into doctors' existing workflows. It disrupted their routine instead of making their lives easier.
Right. And it struggled to account for all the variations in how healthcare is delivered around the world. Studies were showing low concordance rates, meaning Watson's recommendations often didn't match what local oncologists would recommend.
I remember that feedback from Jupiter Hospital. They were quite blunt about it, saying it wasn't really helpful in their context.
Exactly. It just wasn't a good fit. And then there's the whole issue of regulation and validation.
Right. How do you prove that a medical AI system actually works and is safe to use?
That's a huge question. And there was debate about whether Watson for Oncology should even be classified as a medical device.
Because it was making treatment suggestions.
Right. But it wasn't directly diagnosing patients. South Korea, for example, didn't consider it a medical device because its recommendations were based on research papers, not on direct patient examinations.
Interesting. So what was IBM's stance?
They argued it was health software, not a medical device, and therefore didn't need the same level of regulatory scrutiny.
So it kind of fell into a gray area.
Exactly. And unlike drugs or traditional medical devices, it didn't go through rigorous clinical trials.
So how did they validate it? How did they try to prove that it was effective?
They relied on concordance studies comparing Watson's recommendations to what doctors would recommend. But the problem is, those concordance rates varied a lot from study to study.
Suggesting it wasn't consistently reliable.
Exactly. And this really highlighted the need for more robust, standardized ways of validating medical AI.
So how did they actually go about validating the model itself? What were the challenges there?
Well, the fact that it was primarily trained on MSKCC data was a big one. It raised concerns about whether it would generalize well to other populations, other healthcare systems.
Yeah, it's like if you only ever studied textbooks from one medical school, you might not be prepared for the real-world diversity of patients and diseases.
Right. And then there was the use of synthetic cases, which are basically made-up patient scenarios. While this can be helpful for training, it also introduces the potential for bias, especially since those synthetic cases were likely based on MSKCC's data and practices.
So it could be perpetuating the same biases that were already a concern.
Exactly. And there were questions about the size and selection of the training data, whether it was truly representative, whether there were enough cases to draw meaningful conclusions.
So even the quantity and quality of the data were under scrutiny.
Right. And then there's the whole challenge of dealing with unstructured data.
Right.
Extracting meaningful information from doctor's notes, lab reports, all those messy human-generated documents, and integrating that with structured data from electronic health records. That's a huge undertaking.
Yeah, and ensuring the data is accurate, complete, consistent, that's a challenge in itself.
Absolutely. And then you have those fundamental issues that kept coming up, the MSKCC bias, the simplistic recommendations, the lack of adaptability, and the black box nature of the system. It wasn't always clear how Watson was arriving at its conclusions.
So even if it gave a correct recommendation, you wouldn't necessarily know why, which makes it hard to trust.
Right. And this lack of transparency was a major concern for both doctors and patients.
Okay, so before we wrap up, I want to dig a little deeper into the technical side of things. How did Watson actually process all this information? What was going on under the hood?
Right. So the NLP was really crucial, especially for understanding the medical literature. Watson used a whole array of NLP techniques to analyze text, figure out the context, make inferences, identify relationships between concepts.
So it was like teaching a computer to read and comprehend medical research papers.
Exactly. It had to understand medical terminology, the grammar, the structure of the sentences, and then draw conclusions based on that information.
And it wasn't just looking at individual words, it was understanding the meaning of phrases, how they related to each other.
Right. They used statistical analysis to identify phrases that were statistically related, even if they weren't explicitly linked in the text.
So it could find hidden connections that a human might miss.
Exactly. And it wasn't just one algorithm. They were running multiple algorithms, over 100 different NLP techniques, to try to get the most accurate interpretation of the text.
Wow, that's impressive. And how did it handle the patient data?
Well, it pulled information from electronic health records, family history, prior visits, test results, all that stuff, and then tried to summarize the most relevant aspects for each patient.
So it was like creating a personalized medical profile for each individual.
Right, and they had a separate system, Watson for Genomics, specifically to analyze tumor DNA and suggest targeted therapies based on that.
So it was really trying to personalize treatment down to the genetic level.
Exactly. And the goal was to integrate all this information, the medical literature, the patient data, the genomic data, to come up with the best possible treatment recommendations.
So truly holistic approach.
Yeah. But as we've seen, it didn't always work out that way in practice.
So what are the big lessons we can learn from the Watson for Oncology experience? What should people be thinking about when they're developing or implementing medical AI?
Well, I think the biggest takeaway is the importance of validation. And not just any validation, but multi-stage, rigorous, transparent validation. You need to test the system thoroughly at every stage of development using different data sets, different patient populations, different clinical settings, and you need to be open about the results, both the good and the bad.
So it's not enough to just say, hey, our AI is 99% accurate. You need to show your work, explain how you arrived at that number, and be transparent about the limitations.
Exactly. And then closely related to that is the need for multi-institution training. If you want your AI to be truly generalizable, to work in different hospitals, different countries, you need to train it on data from multiple institutions, not just one.
So avoid that single institution bias that we saw with Watson.
Precisely. And beyond those two big ones, there are a few other key lessons that I think are really important. One is managing expectations. AI is a powerful tool, but it's not a magic bullet. It's not going to solve all of healthcare's problems overnight.
So don't overpromise and underdeliver.
Exactly. And then focus on workflow integration. You need to make sure your AI fits seamlessly into doctors' existing workflows, that it makes their lives easier, not harder.
Otherwise, they're just not going to use it.
Right. And then transparency is crucial. Doctors and patients need to understand how the AI works, how it arrived at its recommendations, so they can trust it.
So no more black boxes.
Right. And then strong collaboration between tech experts and domain experts. You need both the technical expertise to build the AI and the clinical expertise to guide its development and ensure it's actually useful in the real world.
So it's not just about building a cool piece of technology. It's about solving real-world problems.
Exactly. And then maybe start by focusing on specific use cases, narrow problems that the AI can solve really well. Don't try to boil the ocean right
You
away.
take it one step at a time.
Right. And then finally, I think it's crucial to think about the ethical implications from the very beginning. AI has the potential to do a lot of good, but it also has the potential to do harm.
So we need to be thoughtful about how we develop and deploy these technologies and ensure they're used responsibly and ethically.
Absolutely. It's a complex landscape, and there are no easy answers.
Okay, so before we let our listeners go, I want to bring up one more point. We've talked about the challenges of validating Watson for oncology, but I'm curious, how does that compare to other medical AI applications that have been more successful?
Yeah, it's a good question. And I think it's really instructive to look at how other fields have approached validation. Take AI for diabetic retinopathy, for example, which is using AI to detect eye disease from diabetes.
Right, that's been one of the success stories of medical AI.
Exactly. And one of the reasons it's been successful is because of the rigorous validation methods they've used. They've measured things like sensitivity, specificity, AUC/ROC, all these metrics that tell you how accurate the AI is at detecting the disease. And they've done this on diverse data sets, different patient populations, to ensure the AI is generalizable. And they've gone through regulatory approval processes, sometimes even full clinical trials.
So a much higher bar for validation.
Right. And you see similar things in AI for drug discovery. They're using lab experiments, in vitro and in vivo studies, preclinical and clinical trials to prove that the AI is actually effective at identifying new drug targets or predicting how a drug will behave in the body.
So they're not just relying on computer simulations or concordance studies.
Exactly. And even for things like personalized treatment recommendations outside of oncology, they're comparing the AI's recommendations to established guidelines, expert consensus, and they're tracking patient outcomes, treatment response, survival, quality of life to see if the AI is actually making a difference.
So a much more comprehensive and rigorous approach to validation.
Exactly. And I think the key difference is that these other fields have recognized the importance of using diverse training data, using multiple validation methods, and focusing on real-world clinical outcomes, not just concordance rates.
So the bar has been raised, and that's a good thing.
Absolutely. It means we're moving towards more reliable, trustworthy, and ultimately more beneficial medical AI.
So to sum it all up, Watson for Oncology was a really ambitious early attempt to revolutionize cancer care with AI, but it ultimately highlights the complexities of this space and the importance of getting the data, the validation, the workflow integration, and the ethics.
It's a reminder that AI is a tool, and like any tool, it can be used for good or for bad. It's up to us to ensure that we use it wisely and responsibly.
And on that note, we want to leave you with a final thought to ponder. Considering everything we've discussed today, what do you see as the most promising and the most challenging frontiers for AI in healthcare in the years to come? What specific questions should researchers and developers be asking to ensure that these technologies truly benefit patients and don't repeat the mistakes of the past?
It's a question worth thinking about carefully, because the future of healthcare is increasingly intertwined with the future of AI.